that email chain that you had reached
I'm
out
so,
to the agenda, when you had asked for the agenda and the call-in information. I think all of our email addresses are there, but I can copy
oh,
them and put them
okay.
into your
No,
email.
I can take care of it. Don't worry. I just was trying to see what I could pull up as I was on
Oh
my
yeah,
youth.
no problem. And you might be able to find them on the TAC invite, but maybe not. They could be hidden there.
Okay, I'll find it. No worries.
I can send it to you after the meeting if you don't.
Sure. And I didn't necessarily want to talk about it today, but I'm like, oh,
Okay.
this is great information.
Well, thank you for sharing it.
Sure.
Erin, this is Leslie. Is the link the same for this as well as the updated? I just noticed somebody got on a different link.
They logged out and logged back in, Leslie.
Okay, just wanted to double check. Thank you.
Okay, you're good. Good afternoon, everybody. This is Erin with the Department of Medicaid. It's not quite 1:30 and we're still clearing out the waiting room, so we'll give it just a moment before we get started.
That sounds great. Thank you, Erin. And as you see TAC members coming in, if you could just let me know.
I have you, Melanie, and Arthur as of
Oh,
now.
Arthur's on.
But
Okay, great.
make sure he didn't drop. Now that I say that, sometimes it looks like he may have dropped. I will keep an eye out.
I do see him,
Oh.
his camera and mute are on, but his camera's off and mute
Oh,
on.
there he is. Sometimes I get so many pages when I try to scroll. It takes me a moment.
Hi, Arthur. You're still, I think you're on mute, Arthur, if you're talking. Hi. Now we can hear you. Good to see you.
Yeah.
We're going to give it another minute or two to see if some of our other TAC members are able to hop on.
Miranda's logging in.
Perfect. Hi, Miranda.
Hello.
Nice to see you.
You too?
We're going to give it just another minute to let some other people join. I do think we have a quorum now, so that's good.
Kelly. Injections. Knees.
Arthur, I don't think that you're talking to us right now, but I do hear something, maybe your machine every once in a while. You might want to mute unless you are trying to talk.
The waiting room is clear, Emily. If you'd like, I can keep an eye out for our other two TAC members if they join.
That would be great. Thank you. I do think one may be traveling, so it may just be the four of us, but it's good to know that we have a quorum. Thank you all for being here today. I'll go ahead and get the meeting started, and let's just do brief introductions. I'm Emily Beauregard. I'm the chair of the Consumer TAC, and I'm also the director of Kentucky Voices for Health. And I'll ask Melanie, Arthur, and Miranda to introduce yourselves.
I'm Melanie Tyner Wilson. I'm here as a representative of the ARC of Kentucky, ARC of Central Kentucky, and the Autism Society of the Bluegrass.
Arthur has something to say. You he said he's Arthur Campbell Jr. and he is Way King. Representative. He said his name is Arthur Campbell Jr. and he is a representative of PNA. He said thank you.
Thanks, Arthur.
And I'm Miranda Brown with Kentucky Equal Justice Center, and I'm a connector. Thank you.
All right. Thank you all for joining us today. And we've already established a quorum. So let's go on to approving the minutes from our last meeting, which I hope everybody received and had a chance to look over. Any questions or discussion before I call before I ask for a motion to approve the minutes? All right, I'll ask for a motion.
I second.
Thank you. All in favor, say aye. Aye. Any opposed? Okay, motion carries and the minutes are approved. Thank you all. And then we can move on to old business. And we have our usual standing data requests.
Sure, this is Jordan from eligibility and enrollment with DMS. So for our presumptive eligibility members, currently we have 1,466 members enrolled in presumptive eligibility. We have 285 enrolled in emergency time limited Medicaid. Overall, our traditional Medicaid enrollees are sitting at about 147,000. And then MCO, we have 1,318,128 for a current total enrollment of 1,465,388. And I'll put these figures in the chat just so you all can see them.
Oh, great. Thank you.
Mm-hmm.
Any questions about enrollment? All right, Jordan, are you going to provide the 1915C waiver enrollment, or is that going to be somebody else from the cabinet?
Emily, this is Leslie. I'm on. How are you
Hi,
today?
Leslie. Good. How are you doing?
Fine. I will be trying to answer the long-term care questions today.
Okay, great.
So for our active numbers, and these are fluid, I kind of get tickled even from last night to this morning. They're constantly fluid. So our active numbers right now are around 30,825. And our wait list is around 14,649. That includes SCL with 0 emergencies and 3,529. HCBS has 1987, 1987. And Michelle P is 9134.
9134. All right, thank you.
Yes, ma'am.
I know that there are some new waiver slots that are starting to open up. Can you give us, I don't think that I put that on.
I thought you might ask.
Or it might be later on the agenda, but
fine.
if you have any update that you
Yeah,
can.
I can. I thought you might ask, so I include that information. So House Bill 6 for fiscal year 25 allowed us for quite a few slots. So I can give you an update on that. We released communication on 7/31 that we would be releasing the slots and they would be staggered. On ABI LTC, we went ahead and released those on 7/30 and the rest were released on 8/1. When I say staggered, though, I wanted to let you know that in order to prevent a bottleneck effect or to over implode the provider capacity, we did decide to stagger those larger ones out like the SCL and the Michelle P. So I just wanted to let you know that we did stagger those out. We have pretty much a 3-month plan and I can kind of give you that. What causes some more an additional bottlenecking, Emily, is that we have those slots that rotate around every month already. So not only do you have those that rotate where somebody didn't take a slot and they rotate to the next month, but we also had the new slots. So I think what we ended up doing, just a second, I've got it. So 25 additional slots for ABI LTC, and we released those already. Then we had for HCB, Michelle P, and SCL, we did a 3-month allocation plan for the 250 slots for HCB. Month 1 and 2, we will release 100 slots per month and whatever the normal rollover is from each month. And then month 3, we will allocate the remaining 50 slots plus whatever needs to roll over each month. I know that's hard for everybody to understand, but there are slots that aren't taken and they're always in process. So for the Michelle P waiver, we are doing 85 new slots for month 1 and 2 and 80 slots for month 3. And then we will also have those rollovers every month, which I think are around 75. I don't want to quote that for sure, but it's around 75. And for the SCL slots, there was 125 new slots. We do not have anybody on the emergency waiting list, and we will start working through the urgent. So I just wanted to let you know that.
Recording in progress.
So we tried to be diligent. I had left for a little while in previous years and came back when we were allocating those large amounts of Michelle P. And it did not just slow us down. It stopped us dead in our tracks trying to get those done. And I didn't want that to happen again. So I had our sister agencies and we all met together and decided on this plan together. So it wasn't just a Medicaid decision either.
Yeah, that's helpful. Staggering slots makes
Yes.
sense whenever you're trying to deal with
Yeah.
provider capacity. I don't recall the exact number that was approved in the budget, in the state budget, but I feel like it's more than what you just.
So there's for the
Right.
fiscal year 25, it's 25 slots for
Okay.
ABI LTC, 250 slots for HCB, 250 slots for Michelle P waiver, and
Okay.
125 slots for SCL. Now that's
Okay.
just fiscal year 25. So that's all we've been working on. If you
That
remember
makes sense.
for fiscal year 26, we have to do a current evaluation of the waiting list prior to being able to release those. And of course, we have to ask CMS to be able to add those in and release those as well.
And okay, that makes sense. Thank
Yeah.
you.
Yes, ma'am.
Any questions about the new waiver slots? It looks like Arthur may have one. Arthur, you're on mute right now. If maybe you're talking to your assistant. Okay. Well, Arthur, if you do have a question, you can either unmute or put it in the chat. I wasn't 100% sure. And if there aren't any questions,
Yeah. He got a question, but he's waiting until you guys get to the questionnaire of C,
got it.
the HBS waivers.
Okay. That makes sense. All right. So thank you for that update, Leslie. And think we may be going back to Jordan for an update on the unwinding renewal process.
Is this, sorry, which one are we on? How many adults have completed the unwinding renewal process?
Right, that's right.
So for our finalized July numbers, because obviously we're not done with August just yet. But so the total number of individuals that had a renewal due date of July 31st, we had 40,719 individuals. Of those individuals, 36,035 were approved. And 48 of those individuals were approved after termination. So they were terminated for probably non-response, and then they came back and were reinstated. Of the individuals terminated, 907 of those were determined ineligible. 53 of those were no response, or they failed to return their renewal form. The number of individuals that we have pending processing for July is 0, so that's great. That means we've processed all of their documents and completed their determinations. And then we had some members that were extended to August based on some of the flexibilities that we have that are continuing until June 2025. And we had 3,496 of those individuals.
Okay, great, thank you.
Emily, this is Veronica Judy Cecil with Kentucky Medicaid. I just want to note, so we are now, as we've come out of the formal unwinding, you know, there aren't really very many cases that we would consider a public health emergency unwinding case. And we've kind of collapsed everything because we're now going through second round of renewals for individuals that had a first, and then we're going through first renewals for people that enrolled a year ago from today. So, it you know, in terms of like just the unwinding bucket, you know, we had over 1.1 million individuals go through renewal as part of unwinding. And of that, you know, about 83% were approved, which I think is fantastic. And then of those who were terminated, the majority of those, I'm sorry, over half, about 60% were for that non-response procedural reason. So keep in mind that really May was our sort of last large number of PHE unwinding renewals. We had just a handful in June. So most all of the PHE renewals have been completed.
That's great. Yeah, I knew that it was winding down for adults, no pun intended, but of course not starting yet for children. But it's good to know that the overall total of successful renewals was 83%. And I know you all have been allowing as much time for people to, you know, get those documents in as possible. We appreciate that. So I think maybe as we move on with our next agenda, we can look at it not so much from an unwinding perspective, but just renewal from year to year. Thank you for those updates. Any questions about the renewal process or these numbers? Great. So then the next section is really just focused on child renewals. And I know you may not have an answer to this question yet, but perhaps since the last time we talked, do you have a start date yet for child renewals or any response from CMS?
No, the question to CMS is still pending, and we have maintained the flexibility until we hear otherwise. So we have been automatically extending children. And of course, we have a lot of children going through first renewal, you know, that enrolled this time last year.
Right.
So even the really there were some child renewals in September last year, not very many. They might have been part of another case, and so we kept the case together, but we have extended children. If a child is being terminated, it's really for those 3 reasons of, they turned 19 and they weren't, enrolled, then they may get enrolled in a different type of assistance. They moved out of state, or their termination was requested.
Right. That's right. So just because I think it can be confusing, the timeline in which it's, the continuous eligibility applies, or that pandemic era continuous eligibility. If a child was enrolled when the pandemic began, essentially, whenever Congress
Mhm.
passed that part of the law, or until what date? Last year at some point was when some children, if they first enrolled, they weren't covered by this protection. Do you
Well,
know?
we would, we included the extension for any child renewal from September 2023 on. But we moved most of the child cases to beyond that date so that we could cover all children with that flexibility. Does that make sense?
I think it does. I was just, as I understood what you were saying, I thought you were saying that if a child renewed at some point, if they enrolled in coverage last year,
Yes.
they would be renewing this year, and it could happen before child renewals began. But maybe
No.
that's
So now, because we apply the flexibility at the time of their renewal. So if they enrolled in August last year, we've applied the flexibility to them for their first renewal. So they are automatically extended.
They will
for 12
also be
months.
extended. Okay.
Mhm. Yeah.
That's helpful. Thank you. I wasn't being very clear in the way I asked the question, but I think we got to the answer. So,
Okay, good.
okay, so we don't have a timeline there, but they're being extended month to month.
Mhm.
And the other question here that had come up on a previous call is about the Kentucky birth certificates. Do you have any more information you can share there?
Jordan, you know how to answer that question?
Yeah. So, when looking at an individual's citizenship, normally the databases that we use or the data sources that we use is able to capture that information automatically. And then our eligibility staff also have a manual lookup access to what's called the KVETS system, which is the Kentucky Vital Statistics data warehouse, where they hold all of the birth information for births that take place in Kentucky. They don't have it from other states. So anytime a birth certificate would be requested, it would be after we've checked all of those data sources and no information was returned, or we weren't able to find that information. It's very rare that we should be seeing an RFI go out requesting a birth certificate, unless we were just completely unable to verify citizenship. Sometimes we see this with newborns. Their information may have not entered into the data sources yet. But I think we had requested maybe specific examples that we could look at to see what the exact situation was around those requests, and we're still happy to look at those if that can be provided, but it shouldn't be something that happens often.
Okay.
Mm-hmm.
Well, I am glad to hear it. We have absolutely seen them from time to time, and children born in Kentucky. So, sometimes that's some error in, what notice may get sent out, but I'll follow up with Priscilla and to see if she's sent them or can send more. And then Miranda, I wanted to ask you if you had any examples that you wanted to share.
I do not, and it's possible that our other connector, Soraya, may. She's not on the meeting at
Okay.
the moment, but I'll check with her.
Well,
Yeah.
just knowing that there should be a process in place is good just to have that confirmed.
There is, yeah. Best practices for us when doing eligibility is always to check our data sources before we ask for information,
Right.
and that
That was our
includes
understanding.
birth certificates. Yeah. So yeah, if you don't mind to send me, some examples in email or however you want to get them to me, I'd be happy to look into them and see exactly why they were requested.
Okay, yeah, thank you. Any other questions about Medicaid renewals before we move on? So next we have the HCBS waivers, state plan amendment and rate study. And I know Arthur had some questions about that in the chat. Let me pull those up. So regarding the PDS rate increase and corrective action plan, well, why don't, Leslie, if you could give
Yeah,
us maybe an
I've got-
update there,
Yes.
and
I've
then
got
we can
Arthur's
address these
I've got his
questions. You can
questions.
see them, I
Yes,
think,
ma'am.
so.
And I think I can answer question 1, and then if question 2, 3, we might need.
We may need to read them out loud for them to be in the transcript.
Let's see. So I'm just going to kind of give you a summary, then we'll go back to his questions if that's okay.
Yes,
So
that
I'm
sounds great.
giving a summary for the HCBS waivers, the state plan amendments, and the rate study. So DMS updated the 1915C waivers to reflect the new rate methodology that was based on the rate study completed in 2023. DMS had no plans to decrease the rates for any services with the implementation of the new methodology. DMS released those amendments, Emily, for all 6 waivers and the rate study on August the 14th. And I can put that in the chat to solicit for public comment for proposed changes. Let me see if I can put this in here for you real quick. Oh, it says it's too long. I'll email it. How about that? I'll email it to Aaron and get it out to you. Let's see. And then the public comment will go until September the 13th of 2024. And at that point, then we will pull those public comments down. We'll do a question and answer and then post those back onto the website for review. And I can also send, let me see if I can send this for more information about posting public comments, and would be happy for you to comment. We'll take those back. Let me get this here. Okay, there, that went, okay. And then the anticipated time frame for that would be public comment ends on the 13th. Q&A would be posted. Now, our Q&A answers back and being posted on the website is really based on the volume. If we get 2,000, that's different than 200, and 20 unique ones versus 200 unique ones are always different, but we plan on getting that turned around really quick. And then at that point, we would submit the revised application based on the public comments back to CMS for review. DMS anticipates approval and implementation by early of 2025. So, they've got, they have clocks, what we call our clocks. So as long as we can keep negotiating really early on with questions back and forth, that's good. Once we go on a clock, if we do go on a clock with them, then that can be up to a 90-day period back and forth. So as far as the proposed rates for PDS, as it's historically been the case, rates for the services offered through traditional and participant-directed service delivery are equivalent. PDS employers or the participants can pay their PDS employees up to the rates listed in the fee schedule. And I would mention too, Emily, I'll email you the links for this, but because those applications are so long and they're hard to read through and they're not provider friendly or member friendly, we did summaries so that we've got like the summaries for each one of the waivers that you can go to as well. As far as the corrective action plan goes, we do not have anything in formal writing yet, like that's a formal cap. We are meeting with CMS, and we did include our sister agencies on the last call with them, and we will have another call coming up in September, I believe. So DMS, of course, is willing to provide that to you once we have the official cap.
Okay.
I think our next call with them is September the 30th, I believe.
Okay, good to know. We have another TAC meeting in October.
Okay, and let's see. Okay, so next would be the 1915I, and I'm going to speak on that today as the representative's not available. So the 1915I is what we call an HCB, SMI, and SUD state plan amendment. I know it's confusing, but that's what they call the opportunity through the federal government. So it is a state plan amendment. Our 1915I is currently under the administration of the Department of Behavioral Health. And Ann Holland, who used to be with our department, is now administering that program through the Department of Behavioral Health. And they have already started work as administrating rather than waiting till implementation. And I'm going to put her information in the chat. And then Medicaid will remain the authority, the CMS oversight, and the compliance. We're currently working with CMS off the clock for our second round of requests for information questions. And we plan to have those submitted back to CMS around the 30th of this month, so about 10 days from now. We're looking at a hopeful start date of July of 2025. That is a little fluid right now because I've mentioned to you all before, we want to make sure that we have time to do lots of collaboration, lots of communication, and also we've got a companion SMI 1115 that's coming out that they kind of, they're companions to one another. And we don't think that one will be approved till around September. So I just wanted to let you know we would have to be working through all those procedures on the 1115 aside. That takes a little bit longer than any of the HCB projects. So the companion SMI 1115 was submitted to CMS in May, if you remember, and that gives us the authority to reimburse beyond 15 days for inpatient psychiatric stays, and it also allows us to assist with a recuperative care pilot project, which we're very excited about. And this will give folks who may be homeless and in need of care, maybe before or after hospitalization or surgery. This will give them time to recuperate in a safe environment, a clean environment, maybe if they have to do prep prior to surgeries and things like that. I was just going to mention too on the Health and Housing Collaborative, of course, DBH will now with Ann Holland kind of be partnering with us in that endeavor, but we continue to partner with our Kentucky Housing Corporation on many initiatives. If you remember, we had previously partnered with them and had written letters of support for another NOFO opportunity that they were applying for, and DBH sent support as well. The collaborative has mostly been focused on the housing supports under the 1915I State Plan Amendment. And right now our upcoming discussions will be about system alignment between DMS and the homeless management system. And we do currently have, for the first time in history, a HMIS user. That's the data that we can connect our data with the homeless population. And so that's very exciting. And I believe Ann Holland also is going to become a HMIS user as well. And so as far as authors' questions, I was just going to mention, we have not made any final decisions at this time about an RFP. We have in conversations, but we have made no final decisions. And of course, that would be CHFS leadership and secretary to make the final decisions for that. Author number 2 and number 3, if it would be okay, I would like for staff to be able to take that back because I don't want to quote anything that would be incorrect to you on this call. If that's okay, we'll reach out to you directly through email, if that's okay.
All right.
Okay, thank you. Yes, I will have.
Okay. He said, can you please email it to him?
I'm sorry, what did you say?
He said, can you please email it to
Oh,
him?
yes. Yes, that's what we plan to do. So I answered question 1. We will be reaching out to you for question 2 and 3 by email.
Right.
You said, They haven't? You said they haven't decided when. RFP is issued. You said that they haven't decided when the RFP gonna be issued.
That's correct. And there is no final decision made as to whether we're going to follow an RFP process right now. We're still in conversations.
Should I read it out? All of it? He said, what about is there anyone in the cabinet or in the MDS that can tell me whether or not that Medicaid will pay Jerry injection for severe knee pain?
That's one I'm gonna have to follow up on. I'm not the guru that, unless there's somebody on the call that can answer that question today, that's one of the questions we'll follow up with you, Arthur, on.
He said he will appreciate it. For he has 4 people who he said he got 4 people who want to have that jail done. And they call Medicaid.
Yeah, I'll need to follow up on that. Jelly injections are not gonna be my forte, but I don't mind to follow up for you.
He says, okay.
Yes.
So thank you.
Okay, let's see. Emily, I'm gonna go back to, am I next for end of Appendix K flexibility?
Yes, that's right.
I'm sure you've heard all of this information already. I've got kind of a timeline here just because I probably haven't spoken to you about this before, but the federal government, of course, ended the COVID-19 public health emergency on May the 11th of 2023, and the Medicaid flexibilities approved through Appendix K remained in place through November of 2023. DMS's response to the public health emergency ending was in fall of 2023. DMS amended the 6 1915C waivers to make some of the Appendix K flexibilities permanent. CMS approved those changes and they became effective May of 2024. We did stakeholder engagement webinars in September and in March, and described the changes that would be permanent and which ones were expiring. So if I have the links for those, if anybody is interested, we do have resources and FAQ and a 1-pager out on the website, which I thought I could put in the chat for you again.
And Leslie, I'm assuming that all of the flexibilities that you have been able to maintain permanently, those are in place now. There wasn't like a disruption.
Not
And
that I'm aware of, no.
and there's nothing else changing moving forward.
Not that I'm aware of,
The
Emily.
ones that ended are done, and the ones that are permanent are in place. Okay.
Yes.
So we can probably just take this off of our agenda altogether.
And I put the 1-pager and the FAQ.
Okay, great. Thank you. And then you already spoke to the Health and Housing Collaborative between DMS and the Kentucky Housing Corporation, but I did want to see if Melanie had any questions there.
Okay.
Oh, sorry. There was just something posted that as today on a source called Disability Scoop, and they talked about state agencies will be receiving federal dollars for individuals with disabilities, and Kentucky is on the list to be a recipient. And it would look like that they're going to housing agencies, and that it'll be anywhere from $4 million to $8 million.
Melanie, I don't know for sure if this is the same opportunity, but we just recently, like I said, sent support letters in for a NOFO that Kentucky Housing was applying for. I don't know if that's the particular one.
Oh, okay.
We do,
Is this,
it
would it
wasn't
be,
us that applied for it, though. It wasn't
right,
Kentucky
I
that
think it,
applied.
I think
Medicaid.
it was Kentucky Housing
Yes.
Association is what I'm guessing.
Yes.
And the funding will allow states to develop strategies to identify and refer individuals to housing options and provide them rental assistance. Does that sound familiar?
Yeah, it's you'll hear us talk about tenancy supports and things like that in some of our programs, and we are partnering with them. I don't want to speak particular to what you're seeing
Yeah.
out today because I've not read it, but we've partnered with them on several initiatives so far. So we're very excited and so honored to have them as partners here in Kentucky to make sure that we can, provide a continuum of care because we're all working together. So that's a very positive thing.
Yeah, yeah. I can send it on to you if
Yes,
that would
ma'am.
be of help.
I have a meeting with them on maybe the 9th. I can double check with them.
That would be great.
Absolutely.
All right, well, thank you, Leslie. And when you mentioned that the companion SMI 1115 waiver was submitted in May, I'm assuming you're in the DMS right now, is just waiting for a response from CMS?
Yeah,
So-
that one is actually tied, and I know this all gets confusing, but it's actually tied to our umbrella 1115, which is called Team Kentucky. So it's one of the requests that'll be under Team Kentucky. And Team Kentucky was up, it was time for us to extend that demonstration period. So it's tied to the whole demonstration getting approved. So there's multiple let's see, we've got the SMI, I'm trying to think, reentry that went ahead and approved reentry, SUDs under there. We've got several arms related to former foster care. There's some related to employee, or was related to employee insurance. There's lots of things that are under that umbrella. So
are you waiting to submit other components of that, or are you just waiting on CMS to respond to the entire umbrella?
we're waiting for
waiver?
response. The only thing that we submitted that was kind of outside was the reentry, and then they decided for the reentry to fast track 6 states in a cohort that were very similar to the state Medicaid director letter, and they fast tracked us with some other states to get that done. So that's
Which means your implementation plan also has to be done sooner, right?
That is correct.
Yeah,
And there's also will be an implementation plan. The 1115s are a lot harder than most people realize. The reentry requires an implementation plan, a reinvestment plan that we've never done before. This is specific to reentries opportunity, monitoring, and what we call our, it's kind of like our metrics that we have to get approved, and some will be state specific and some will be, we call them our, so I'm losing my acronym here. Then we'll have the state ones, and then we'll have the ones that are required by STCs, I'm sorry, standards of terms and conditions. We'll have those, and then we'll have the federal required ones. So all of that has to be approved, and some of it can work simultaneously. Some of it takes 120 days. Some of it takes 150 days. It's kind of crazy. So even on the companion 1115 that I told you about that we're waiting for approval, even when I get approval, it's not ready to go. I have to write an implementation plan. So we're already working on the implementation plans even before we get approvals so that we can, streamline that quicker. So.
Yeah, that makes sense. Thanks. Well, that's all good information to have. Does anybody have any questions? Right. I think we can move ahead to the school Medicaid grant implementation.
Erin, did you want me to share my screen, or were you going to share it?
I made you co-host. You
Okay.
should be able to share.
Sorry, it's taken me a second. I'm trying to get my mind around Zoom instead of Teams.
We can see your screen now.
Okay, good. And I'm trying to see where it will let me do a slideshow. Apologies. Okay. Okay. So good afternoon, and thank you for allowing me to discuss the Shine Kentucky grant. And Shine Kentucky, of course, an acronym for Strengthening Health Integration and Education for Kentucky Students. We are really, really excited about this. So what I'll do is a little bit of an overview of the project, and then the goals and strategies, and then that first year, our work plan and timeline. So in, I think it was January of this year, CMS released a notice of funding opportunity for $2.5 million for up to 20 states to receive the grants for either implementing, expanding, or enhancing school-based services. It is a 3-year grant. Kentucky went with the option to enhance our school-based services because we have already implemented school-based services and also expanded them. Expanding meaning that we will reimburse for Medicaid covered services for students that have Medicaid or CHIP, and that's regardless of whether or not that student has an individualized education plan. So Kentucky was one of 3 states to receive the grant for enhancing school-based services. There were a total of 18 states that were awarded, but again, we were one of only 3 to get the award for enhancing services. And so there are 2 overarching goals for this project. The first, to increase school-based services provider and staff capacity by at least 40% within 3 years. Doing that through eliminating provider billing barriers, increasing overall capacity of our behavioral health providers in the school setting, and also increasing the availability of reimbursement opportunities to expand behavioral healthcare services across the care continuum. The second goal is to strengthen school-based services infrastructure through availability of telehealth by 25% within that 3-year grant period, through developing and implementing a telehealth program to support access to behavioral health services and provider education. And through both of those goals were based in part because we have identified that there is a behavioral health provider shortage, especially in that school setting. So there are 6 enhancement strategies that we will use. Let's see. I'm going to try to make these a little bit easier to understand if you're not actually involved in the project. So the first, we want to seek to build the staff, enhance capacity and competencies. So we know that there's a need not just for behavioral health providers in the school setting, but also administrative staff that can understand how to bill for Medicaid, because that's a lot to put on a school district to become Medicaid providers as well. So we want to ease whatever administrative burdens there are as well. Outreach and community engagement. So that is, of course, outreach to our students to let them know that these services are available, but also parents so that they know that their children can receive some of these services in school, and also community providers, because we need them to be engaged to make sure if the student is receiving services in the school that there's follow-up in the community if necessary, or also to have those community providers engaged with the school district to maybe even contract or partner with the school to provide those services. Let's see. I can go through each one of these. I'm not sure if that would be helpful or not, each of these enhancements, but one of the highlights is our Shine Kentucky grant program. We are going to award $100,000 to 7 different school districts in order for them to pilot different models of how they are increasing school-based behavioral health services. with the expectation that the lessons learned through those piloting projects that we could have rolled out throughout the state of any of those successful models. And so there are 11 key tasks for the first year of the grant, and this just kind of breaks them down a little bit. We are in the part now where we are gathering who our advisory groups and stakeholders will be, and also completing our final needs assessment. So we've gone through several different we've done a survey from DMS on what the needs are for school-based services. We know that there have been other agencies that have also done different needs assessments. So we just want to synthesize all of those different surveys. And then if there are any other remaining issues that need to be addressed, we want to collect all of that information. And we're going to have a final needs assessment by the end of this calendar year. So again, the immediate next steps right now, we're working on identifying who the stakeholders need to be, developing that stakeholder engagement plan, thinking about the different survey and interview tools that we're going to need to get all the information that we need for our needs assessment, and then present that again by the end of the calendar year. And I didn't know if we wanted to open it up to questions now, or if that is something that would be done through chat.
I think now is great, and thank you very much for this presentation. It's good to see it on paper, and it's really helpful to see the different sort of focus areas that you have. I wanted to ask about any, sort of overarching goals. I know that mental health is a big priority of the administration right now. Of course, we've had a campaign for years to have a nurse in every school. Just wondering if you are with the grants or just any of your other technical assistance, and especially your focus on like workforce improvement. Are you looking at targeting a particular sort of type of provider or service?
We are specifically looking at behavioral health services. So that is our goal, of course, is to expand behavioral health services, but we know that in expanding access to healthcare services in the school setting, that would also include the physical health services as well. But our main priority right now is the behavioral health services.
Yeah, okay, that's good. That's helpful. Thank you. Any other questions?
This is Melanie. I had a question. When you were talking about behavioral health, are you talking about it from the lens of a medical model in terms of like having psychologists or LCSWs, or help me to, I'm just trying to kind of frame what your what behaviors are you looking to provide support for?
So we have a broad range of services that are covered in the school setting, as well as a large variety of providers that are qualified to provide those services. We have a technical assistance guide for school-based services that list all of those, and I will put a link to that in the chat. That will tell you all of the services that are covered. So let's see, there's different assessments would be covered. Psychotherapy is covered. There's substance use disorder treatments that are covered. Family therapy. So, I mean, it really is a large variety of services that could be provided in the school setting that we do cover. And then also to your point about psychologists. So it again, psychiatrists, it could be licensed clinical social workers. There's a number of providers that we consider qualified for the school setting.
And the age range, would it be kids as young as preschool to children that are in high school?
So it does school-based services covers ages 3 to 21. I'm just depending upon our final needs assessment. I can't say for sure if we would target a preschool age or not. because it is behavioral health focused, it most likely would be middle school and high school. But again, if our needs assessment says that we're, seeing a lot of 3rd through 5th grade struggling, we would adjust our priorities there.
Sarah Vanover, who's with Kentucky Youth Advocates, has written a nice book on mental health issues in the very young child. I don't know if that's something, that's just why it popped into my mind, because she saw that there was such a great need for support beginning at that really young age. So just a FYI.
That is helpful, and maybe that is someone we reach out to as a stakeholder. If you don't mind to drop that information in the chat. And of course, all the information that's available on adverse childhood events, maybe it is something that we start looking at the earlier childhood events too. So.
Okay.
Erica,
I'm on my phone, so I don't know if I'll try to put it in the chat, but yeah, I'd be happy to do that.
Thank you.
Melanie, this is Erin. If you want to email it to me later, I can get it to Erica.
Thank you, Erin. You're always saving me. I appreciate it.
Erin is fantastic. Erica,
Yes.
I wanted to just follow up on that question about more early childhood. I'm assuming that you're talking about programs like a preschool program that might be located within a school, a K through 12 school, or could school Medicaid actually, like the, Medicaid free care rule kind of that was reversed and that allows for schools to bill Medicaid and also get that administrative rate. Could that be happening in preschools that are outside of our K through 12 system?
So our local education agencies, which are the school districts, are the Medicaid providers. They're the ones who enroll. So it would need to be a
Through the LEAs.
Yes.
Okay. That's helpful. And of course, just say, Melanie, this is probably information that you know, but even if it wasn't, school Medicaid as we talk about it now, is this kind of a program that schools can, bill for Medicaid services outside of IEPs, other programs that may serve young children could potentially have Medicaid services as well. It may be a little bit separate in how it's administered, but there wouldn't be necessarily a reason that they couldn't provide those services. Any other questions about school Medicaid? Okay, well, we're very excited to see this getting started and look forward to getting some more information as you all get some pieces in place. I understand the grant is like underway, right? You had an automatic implementation date. You're just kind of in the planning phase right now.
Yes. We were funded beginning July 1, and we were notified of our funding, I think,
like the week before.
The week before.
Yeah. All right. Well, thank you, Erica. We appreciate it.
Thanks, Emily.
The next item here is the DMS surveys of Medicaid members and stakeholders. I think both surveys have ended. So just wondering if you all have any data you can share with us yet.
I do not yet. We did extend it a little into last month. So we are still kind of culminating the responses. So I would guess by the next meeting in October, I should be able to present some information.
Okay, great. We'll just keep it on the agenda for October then. Thank you.
Sounds good.
And then the next item here is the access to services form that Angie's been helping us with.
Yes, and you gave me feedback in July. I don't have any problems with that. I don't know if you want me to pull it up for one last look and then we can get it rolling.
Yeah, that would be great.
Okay,
I
I'll
think
take myself off camera while I do that though. So I'm
if
not
we can just finalize that so that we can start using it, that would be fantastic.
all right. I have the same issue as Erica because I am used to Teams, but Aaron, if you would give me access.
I did.
Thank you. Okay. So this is what was provided in July, and we determined that yes, in-network would be here. The word "and" was included, as well as if available. Date you first requested an appointment, and if there were any offered. Appointment date if accepted, if one was provided, and then given these choices. Anything else you needed to know? Looked good to me.
Okay. Thanks for just going over it again. And I'm assuming that this is going to be a fillable PDF. I think we talked about that. And then eventually it'll be a form that people can fill out online. But for now,
Yes, the expectation is to put it online, and then they would be able to fill it out that way and somehow get it to our inbox.
yeah.
So
Okay.
that could take a little bit, but we'll get on it if everybody's good with how this looks now.
Any other feedback that TAC members want to provide? I feel like this is a good start that we can learn from. Oh, it looks like there's a typo in that provider name, but that's okay. I'm sure you all will take care of those things. And, you know, as we see it being used, I think we may have to make some adjustments, but
Sure.
I really appreciate you all working on this. I'm looking forward to seeing, you know, how people are able to report and if that can give you all more information so that you can really look into where there might be gaps in the networks. And I guess one question that I have, not so much about the form, but about, you know, any follow-up that people can expect. Do you anticipate being able to actually respond to someone and offer to help them to find a provider, or maybe alert the MCO and
The
give them a
expectation would
nudge?
be if we have the MCO information that we would forward that to them. I mean, there should be a closed loop process to this.
Okay. If the MCO hasn't, you know, necessarily been helpful up until that point, is that when DMS would kind of step in and try to?
Well, we
help
would
from
ask
that?
them, we would send it to them and say, you know, we've gotten this, what's this? Could you reach out and what was
Need
the
more
problem
attention to this
before,
particular
you know,
case.
you know,
Okay.
it'll depend on what some of the feedback we get.
Okay. All right. Any other questions about it? Angie, would you be able to let us know when it's live
Sure.
and where it's going to be like housed on the website so that we can share it?
Absolutely.
Thank you. This would be a really good topic to have on one of your monthly stakeholder calls. I know that you've now expanded the topics for the stakeholder calls that were originally sort of started around the Medicaid renewals process and unwinding. But
Yeah, I probably once we get it up and online, that's something we could certainly add to
okay, great.
One thing that just popped into my head was doing the same thing for NEMT. Because the transportation cabinet does have a survey and it's always glowing. And and I don't know, I'm sorry, I don't want to create anything, but it just, you know, it was just a thought.
I like how you think.
Your thought, you get to take it and run with it.
I like how you think. Well, you know, I mean, it is a Medicaid service. I think we've just been talking in terms of providers. And if, you know, if this was an online form and it could be a medical service, or you could choose transportation as the service that you need, like it could all be, I think, integrated pretty easily. But I do think that transportation is a Medicaid service and we should know whether or not somebody's had trouble getting access to transportation. I wonder if there's a way to just add brokers to that.
Thanks, Dr. Terry. No, I'll look at it.
Sorry.
I'll see if there's
But
any adjustments to this particular form. Or if
yeah,
we can look at something different.
I have to agree that the data that, is collected through the Department of Transportation doesn't seem to really reflect the experience that people have. And I just think that's probably a matter of who even knows that they can provide feedback, or where to provide that feedback. And it's also, I'm curious to see how many more people will have access to transportation because of the new regulation. But of course, that still depends on whether or not they're familiar with those changes and how the broker is administering that. I'm glad you brought it up. Thank you.
Might take it a little bit longer, but I'll see what we can add to it. Or if we need to look
or just do something similar but
in a
different.
different avenue.
Yeah, I think either could potentially work. The next item here is the presentation on the 2022 A-TRIP, which is the Hospital Rate Improvement Program and the Alignment of Quality Initiatives. I know we've kept this on the agenda because I think the expectation was that later this year you would be able to provide more information. Do you have that?
Actually, the presentation I have is something that I presented to the hospital TAC in February. So I just changed the name to the consumer TAC and added the date for today. So I can go through this. It's regarding the program results from 2022 for the A-TRIP program.
Okay.
And I'm going to take myself off camera. Oopsie. Are you still seeing the form? Or are you seeing the presentation?
I can see your presentation.
Presentation.
Okay, great. Okay. So as I mentioned, this is the Hospital Rate Improvement Program 2022 results. But in order to get to that, I wanted to give just a short overview of what the Hospital Rate Improvement Program is for those who may not be familiar. But it's basically a directed payment program that allows us, DMS, Medicaid, to provide enhanced payments through the managed care organizations to advance goals of the Medicaid program to the hospitals. It's based on utilization delivery of services. It's supposed to advance at least one goal of our Kentucky Medicaid's quality strategy. We evaluate it at the end of each program year to measure progress. It's submitted to CMS annually for approval. Any changes, we have to do this every year. Any changes to the directed payment program, also known as a preprint, we have to update. And if, that also gives us opportunity to potentially add measures. It's funded through a hospital assessment per this statute, 205.6406. And a directed payment program is designed to achieve two main objectives: to improve quality outcomes and maintain access to services. The 2022 A-TRIP program, we work collaboratively with the Kentucky Hospital Association. In 2022, 84% of the hospitals achieved at least 4 of the 5 hospital-specific goals, and 50% of the hospitals achieved all 5 hospital-specific goals. Here are the data metrics that are specific for 2022. There are asterisks assigned to some of these that let you know that they're applicable to certain hospitals or not applicable to certain areas. But the CAUTI is catheter-assisted urinary tract infection. That's what that stands for. C. difficile. It's a GI type problem. Hospital readmissions, sepsis. There were psychiatric specific measures. Excuse me. Safe use of opioids and rehab specific measures, specific to discharge of community, and also social determinants of health screening. That was started in 2022, and they will be being measured on that for calendar year 23. We're in the process of getting 2023 reviewed. So here are the list of all the 2022 quality measures and what the benchmark was and the hospital goal for each measure. And then the results. So for the providers meeting the goal for 30-day readmissions, 78, and there were 99 providers that were eligible for this. And below just gives you the percentage of for each quality measure, what was met. And as you can see, the catheter-assisted urinary tract infection, the low volume for rehab or LTAC, was the least positive and improving or obtaining the benchmark. I'll let you look at that for a second in case you have any questions. And obviously I will provide these to you after the meeting. I'll send them to Aaron. The continued results on this screen, the C. difficile low volume for rehab or LTAC was the least positive, the most negative. However you want to look at that, as far as achievement of those measures of the providers in which they were eligible. But they did pretty well in certain areas.
And these are the numbers here are the number of hospitals, right? When it says providers meeting goals,
Yes,
it's
yes.
hospital systems, yeah. Yeah, this
Hospitals or rehab, it depends on, like, for example, this C. diff volume
Whatever the
non-rehab,
facility.
and then you have the rehab. So this gives you the total number who would be applicable for or eligible for these particular measures.
Right. So when are you expecting to have data from 2023 available to share?
It's being reviewed and audited now as we, so it probably be the first of next year before we get the final.
Next year, okay.
And I'll
And
put it on my calendar to do the same thing for you. How about that?
that sounds good. And then I'm assuming that when you see rates that are lower, like around C. difficile, is the hospital association just working with those hospitals, particular hospitals, to improve those rates? Is there anything that DMS is doing? Or is
Well,
it
they don't get paid for, additional, depending on, this is what this is based on, the quality measures. In order for them to get additional payment, they have to meet certain qualifications as far as the benchmark for these. So they may not
the
get.
incentive is
Yes,
essentially
the incentive is, yes. So they're all incentivized, thank you for the work, to perform to the benchmark or better.
okay, yeah, that makes sense.
But we also look at trends, as well, because if for 2023, if the C. diff is below this number, then, obviously that's something that we need to address a little bit more closely. I'm sorry.
I think Arthur had a question.
He wanted to know what does the hours of physical restraint use mean?
That's a very good question, Arthur. I'm not exactly sure. It's in relationship to certain psych facilities, and that would have been established in the benchmark. Let me go back and see if it's specifically addressed here. No, we were establishing a benchmark for 2022 data. So basically for that, they were just reporting what the average hours of, or the hours of seclusion was. So we will know more about that for 2023.
I wonder, Angie, if the quality measure itself sets a parameter for what is considered appropriate.
Some of them do, some of them are, but but some of them we have to establish a benchmark based on the data that we're seeing. So if, for example, if the hours of restraint are 10 hours, we don't want 10 hours of restraint, obviously. So we would have to, would have to see what the average hours were, and then evaluate if that's appropriate based on certain criteria for the facility, for that type of facility, for them to be restrained. Obviously, the lowest number is what we would be going for.
Oh, yeah, I mean, I think the benchmark helps to measure then are you
Right.
improving or declining? But do you have a reference for these measures that you could share with us, just that has, maybe some additional details that Arthur could see in regards to it?
We'll look into, I'm sure we do.
Yeah, that would be helpful. Thanks.
I do believe that particular metric relates to, this is hospital, keep in mind, this is hospital. So this is about hospital-based inpatient psychiatric, is what the metric is tied to.
This one right here. He was wondering if you can email him this document that is being viewed.
Yes, absolutely.
Yeah, I think this with the is it NCQA measures is it NCQA?
Some of these are more hospital specific measures, so they wouldn't be NCQA HEDIS measures. Some of them, most of them are not, except for readmissions. But I can certainly get the more specific information on these for you.
That would be great. And another question that I had, I know that now outpatient services are
Yes.
also participating in the rate improvement program. So is that something that you also have metrics established for? That
Yes.
started a little later. Okay. I think that would be helpful to see next too. So it'll be early 2025 when we
For
can
2023.
2023 data. And at that point, would you have benchmark data for the outpatient program?
I don't know. I'll have to go back and look what all those measures are. I'm thinking it won't. 2023 is the benchmark year for the majority of these, so we should have by that time.
The only other thing I wanted to bring up, I know with the social determinants of health assessment that hospitals are now required to do, is I think that that's a very good step for hospitals to take and to then be tracking. But my understanding is that while they could technically be doing it through KHI, through the Health Information Exchange, the hospitals aren't using KHI right now. Is that which would integrate it into their medical records. So is there any information?
And Connect.
Right. But I don't think that
share
hospitals
information
are
back and
really
forth.
using it, if I'm understanding that. They can also use, do an assessment outside of the KHI Connect system. Is there a way that you're able to collect that data from hospitals if they're not doing it through KHI?
Well, if they're doing it through Connect, because Connect does connect to there's an exchange of information between the two systems.
Right. And my understanding is that they're not doing it through Connect, generally speaking, in a way that it would integrate it into the system and between their medical record and the state. I could be wrong about that. But when they're not, when hospitals are choosing to do the social determinants of health assessment, it's not through Connect or KHI. Is there a way that you're able to collect that information?
Well, we do get that information through this project. I mean, with the, we have to audit each of the measures, well, but the majority of these measures are audited just to see what they are collecting and what, in the particular model that they're using to collect this information.
So would you actually get then the results of it, an assessment, or only that they completed the assessment?
We could do either. Right now, we're looking at if they completed the assessment.
Okay. Yeah, I feel like if we're gonna learn something from this, knowing what those assessments are telling hospitals and how, hospitals maybe then following up with additional resources or, care coordination or case management or whatever the case may be, would be really helpful. But I think having the hospitals do the assessments, of course, is a good start.
I think Norton Hospital or that hospital system is starting to use Connect to do the
good.
assessment. So I mean, it's brand new, and Andrew Bledsoe told me that last week. And so it's, I mean, it makes sense because if they do that, they can close the loop and in the referral. But and it might be that they've started doing it because of this new quality program that Angie put together. So I too hope that more and more of them, start using that system because it already exists and, you can count things on it, but we'll see.
We didn't initially make it a requirement. We wanted them to get used to asking these questions, but they did have to ask, at a minimum, the CMS questions. So initially they were given the choice to do either, but I think, and including that, that some of them or majority of them probably are using Connect, but I can find out the specific numbers because it does help with that closed loop and it allows that care coordinator at the hospital or whatever to, if there's something that they need to give them a resource, helps with the resources. And I think that's why a lot of providers are using it.
Yeah, exactly. Well, I'm glad to know that Norton has started, and yeah, if you could just update us on other hospitals that might be using it and what we can learn from them. I think that's really where I'm going here, but I'm happy to hear about Norton because they're a large system and they happen to be mine. So I'll give them kudos for that. Anything else?
One more thing to share. It's showing the comparison of the 3 directed payments. If I can find it. Allow multiple sharing. Here we go. All right. I'm hoping you can see this. But this is the quality measure programs for 24-25, comparing the HRIP, the UK U of L, and the MCO value-based purchasing program. Yellow constitutes that's the same between the HRIP and UK U of L. The green is UK U of L and MCO BBP, and the blue is all measures. So we're continuing to work with all of our HRIP programs to be more aligned. It's a little bit more challenging for the hospital specific, because, we're looking at certain things such as sepsis and blood cultures and CODI and C. diff. And you can't necessarily do those on an outpatient basis, and the UK and MCO VBP are are HEDIS driven for the most part. And so there aren't HEDIS inpatient hospital measures. So there's a little bit challenge there, but we're trying to get them more aligned in the next couple of years. We hope to see that.
Yeah, this is very helpful to see. The legend, I'm trying to figure out if I understand.
Similar ones so yellow, it's in both HRIP and UKU of L
I see
measure.
that now, yeah.
And
Okay.
green
So that
is,
you're just kind of cross-referencing them between the two.
yes, to help
Yeah.
you, to
Got
see
it.
what is similar.
All right. Yeah, thank you for sharing that. And I think you're probably going to email this to us, but I would definitely
Yes,
like to
ma'am.
hear that.
All right, I think I'm done now.
Well, thank you, Angie. We appreciate it. The next item here is language access. And we've been, talking about this for the past many meetings now about a decision tree that could help people to sort of navigate what type of language service they need and how to get it, essentially, and looking at what services DMS and the MCOs are currently providing for the following populations, which we have listed out here on the agenda: people who speak different languages, people who are deaf or hard of hearing, people with speech impairment, and people who are nonverbal.
Hi, Emily. This is Danita.
Hey,
And
Danita.
I have put together just a short presentation just to talk about what we have done so far and where we are now. I know, like you mentioned, we've been talking about this for a while, but I think what this presentation will do right now in regards to that decision tree is just give us an opportunity to answer some more questions and try to get some clarity about that specific document. So, like Miss Parker, I'm going to turn myself off video and we'll just start from the beginning of the presentation. I'm going to share. I'm looking for my share button. So, oh, there we go. Okay, can you see my screen and am I in presentation mode?
Yes,
Yes.
Okay,
thank you.
thank you. Okay. So just talking about the language and communication, just as I mentioned, this is just a high level overview of, we've not just had from the consumer TAC, but several TACs have asked about this question about the interpreter services and language services in general, what the MCOs are doing and how DMS can better streamline those services. As we've been discussing this subject with the TAC, what we've been showing them that we've been using as our point of reference is the federal guidance for interpreter services. So the translation and interpretation services for Medicaid comes from the Health and Human Services, and this is the guidance that can be found on the Medicaid website that essentially tells us that we need to follow Title VI of the Civil Rights Act, that those language services are available for those individuals with limited English proficiency, and that we have to follow that Section 504 of the Rehab Act of 1973. It talks more about the reimbursement, but we won't go through all of that. But this is part of that federal guidance that we use to help guide our managed care providers as our managed care organizations, as well as the providers. We also are following the Section 1557 final rules that have recently been released. So we have shared this also in these I'm sorry, in all the other previous tax. This is just a breakdown of some of those frequently asked questions that specifically apply to the interpreter services. And I just wanted to include this in the presentation just as a quick link and reference point to that section 1557. I don't want to go into this because we are going to have some other guidance that kind of breaks down and tells us how to specifically apply that to DMS. But just a reference point for you all to look at because it specifically addresses some of the asks that you all have for DMS. As far as the managed care organizations um, are concerned, in regards to the guidance that we have very specifically to them within their contracts, we have the following language that is available to all 6 of our managed care organizations that talks about the appropriate foreign language or the oral interpreters, which is what we talk about a lot within these tags, that they also must have those written materials and that they should have staff that's able to address those very specific needs that you talk about in that decision tree document. I just highlighted those very specific asks that you all have requested from us. And I wanted to put these in this presentation just to be sure that we're clear on your ask. And if you're not, this will give us an opportunity for you to make sure that we have those correct. So what I have here is that you wanted those very specific populations identified for that decision tree, which were those limited English proficiency, American Sign Language, people with speech impairments, and those individuals who are nonverbal. You've also asked for us to create this one-page document that we could share. We've been working with the managed care organizations to help us provide that information with those language access supports. This decision tree is this one document also. So that would be 2 documents if I'm sure if that's the clarity that we're looking for. So you wanted that one shared document, but then there would also be a decision tree that we're looking for those specific populations. That would be one point of clarity that we're looking for. And then coming from all of this information that you're asking from us, there were some still questions about what those pending recommendations would be for the MAC. We had mentioned a provider letter and then also a notice that was in plain language. So we had worked on that one-page document, and this is something that Angie had shared the results of with this tax specifically, and just reviewing how the process on how we went about getting that information. We requested from all the managed care organizations if they would please provide us with what they are doing in regards to their interpreter services and any of their American Sign Language processes, as well as those internal processes that they have. So we gathered all of that information and we tried to take from that information and create that one-page document. So once we received all that information, we worked with our communications team internally. They pulled that information together and we worked with our human service compliance analyst who took the time to review all of that information, all 6 of our managed care organizations, their phone lines. She looked at their website, went through all of that information to see how easy it is to find an interpreter, if those phone lines, if you could directly get to an interpreter just by asking for an interpreter. She created a document for all of those managed care organizations and just outlined if there were challenges on the website, if this information was easily visible on the website, if when she contacted those phone lines, if she could quickly reach an interpreter, if when she went to the website and she typed in the word interpreter, could she find an interpreter easy? Did that information come to her with ease? So she took those steps to find out that information, and then we shared that information with the managed care organizations. As she was doing that, from the DMS perspective, we know that there were some managed care organizations that were also in the process of reviewing their websites themselves. So as far as phase 2 goes, there may be some managed care organizations that are updating their websites. That is the communication that we're not yet established as far as phase 3. We don't know if there's going to be updates based on our findings yet. And then as far as phase 3 with the one-page document, we're still pending on what our next steps might be with that document based on those findings. Because, as mentioned, there were some challenges when we looked at that one-page document. So I did a second request for information with the managed care organizations to better understand the information in regards to those very specific populations and how we could pull together this decision tree. We again was working with our internal communications team to try to get a visual document that could best, lead through the steps of this decision tree. And so we were kind of coming up with some roadblocks on what exactly is the best visual. So just thinking about how people come into the Medicaid system through different doors, that's where we were coming up with the challenges. And so we did this second request on, what are your very specific processes for these very specific populations. So there was lots of great information that the managed care organizations provided to us. And so I didn't want to put multiple slides up here. So I kind of just gathered what was common between all of the managed care organizations. And so, these are some of those common things that we find that all of them, have that TTY line, that there is an opportunity for individuals to have, that three-way calling representative, that three-way calling available, and that they do have those opportunities for those in-person interpreter requests. Acknowledging that we have talked about, there's some challenges with the 3-day time period and the 5-day time period. Those were some things that we had talked about, maybe streamlining and addressing. We know that each of our NCOs offer that written material, which is one of the things that we saw back in our federal guidance. Our NCOs, they talk about that their websites and their information kiosks, and they have all of the technologies are available and accessible to these very specific populations. One of the things that was identified for these very specific populations is that when they take their health risk assessments, that the members are assessed in a way that helps to identify any special communication needs that they may have. So once that assessment is completed, there is an alert that's created on the member's record. So when that alert is created on their record, they are assigned a case manager. That case manager then becomes available to help assist that member with any specific needs that they may have in regards to getting that interpreter services or any additional supports and systems that they may need or that they may need to get through the system. So this kind of leads me through the decision tree, and maybe this is where we can get some clarity for you, from you, I mean. So as they provided that information, I'm looking at a decision tree like this, and the questions that I'm coming up with from this decision tree is that as a member comes through the system, members come through in different ways. Some member comes through and they may go directly through whatever that agreed outcome for services may be for them. Some members may need additional supports, and then there may be some members that are going through the system and we may not be able to address their specific needs without some additional external support. So the question for the decision tree is, were we envisioning this to be like a living document for each specific population that you have listed? Because we know that those needs may change. And if that is the case, then, the document may continue to grow, and with
Yeah.
that create unintended consequences. So I think that was one of the barriers as we talked about creating this document. So we might not answer that now, but that would be one of the questions that we would want to answer. And I'll move on through and we could just kind of table that question and come back through it because this is very short. We're almost at the end. Just to say that, this is where we are now. We're thinking about streamlining all system processes. That is our goal because what we recognize, when we talked about these very specific populations, interpreter services, where ASL comes in, and especially and including those with limited English proficiency. This is not just a DMS issue. This is a cabinet-wide goal. So we have established work groups. So we're bringing in people that are, not just from DMS. So we're wanting to hear, what processes you may have in place for your organization. What are some other answers that we might have to address this? So we have a work group that's meeting. Our next meeting is September the 3rd to try to help bring in other ideas, other perspectives to help us through this. Again, the one pager is currently under review for those final edits. And the overall objective, of course, is to reduce these barriers that the consumer TAC and other TACs have identified. And we know that that goal is to help achieve, the equitable outcomes and access to healthcare, and to be able, to have individuals be able to talk to their providers in the way that helps them to achieve their goals. And so that is the end. And I think maybe we can address those clarity questions if you have any answers for us.
Read. Can you send me this document? Okay. He was wondering if you can send him that document. He thinks you. He is. He thinks he's really. Yeah. He thinks he's real disappointed. But he has to read it before he says anything. Thank you.
We're happy to share it with you, Arthur.
Yeah, and thank you, Danita, for your presentation. Just to your kind of question about whether it's one page or multiple documents potentially, and how things change over time. For me, I think I'm thinking of this decision tree as a guide for someone who is a Medicaid beneficiary, or maybe a family member, or someone who's assisting the individual. That could be a connector, community health worker, case manager, but a guide that somebody could use to identify, this is where I go for language services. And if I'm unable to get the service that I need by calling the MCO or calling DMS, or, asking my provider for an interpreter, then this is the next step that I take. This is where I would report the problem. This is, the process that I would go through to, complain or file a grievance or an appeal, whatever that is. So really, like, how do you first access the service that you're looking for? If you don't get the service, what do you do next? That's what I have in my mind. And if there's more than one entry point, as you mentioned, I think that is worth including in the document too. Now, it may be that other people have other thoughts on that. And because we have 4 populations that we've identified, I could see there being a guide for each population.
No, I think that makes sense, because I think what we were thinking is that how does each of these populations access service? as opposed to what you described. So I think that we weren't exactly thinking about the same end result as far as the decision tree document. So that makes a lot more sense, and kind of pulls that request together. So I think that that is something that we can definitely work with, and I appreciate that explanation.
Yeah, and Miranda, you may have thoughts, of course, any of our TAC members.
I think you clarified it well, Emily, and Danita, when you're talking about the working group, I'm assuming that's just an internal working group, not an opportunity for stakeholders to weigh in, correct?
It's an internal work group, but I mean, we would never not say that we wouldn't want our stakeholders or our partners to provide feedback to us. But right now, it's an internal work group, and we're trying to come together to figure out right now what our internal processes and how we can best streamline those processes and figure out how to improve upon those. I think that one thing that we can do is when we have these work group meetings, that we can come back to the TAC and report out what we're finding. If that sounds like something reasonable for the TAC.
Yeah,
that sounds great.
Any other thoughts now? Okay. Well, I appreciate your work on this, and I think what our original thought was, let's make some recommendations, but we wanted to take a step back and first better understand how the system is currently working and what services are being provided and where there might be gaps before we made other recommendations. One other thought that I had is, of course, we've talked about the MCOs, but when I say DMS and MCOs, I want to be sure we're including any Medicaid members that also are fee-for-service. Yeah. And that may include the, providers that are working with them, in terms of like the case management, home and community-based service waivers, that sort of thing.
Yeah.
So
thank you.
Yeah, just to make sure that we are including them. All right, our next item is new business, and I know we are short on time at this point. Before I cover A, I just want to ask Arthur, do you have your guest on to talk about the Michelle P. waivers? Okay. So okay. We'll continue to wait on that. We can just include it on the next agenda unless you tell me otherwise. I did just very briefly with the new federal rules that have come out recently. I think we've had a little bit of discussion at the TAC. One of the recent MAC meetings, Commissioner Lee had given a presentation about the Beneficiary Advisory Council and, DMS's plans to set that up. And I don't know that we have a whole lot of time to discuss it now, but I did just want to kind of put a plug in for the consumer TAC being involved in that in some way. Veronica, do you have anything to share there?
I can say that we will absolutely include stakeholder engagement, and really feel like that's necessary for how we move forward with both the MAC and the BAC changes. We are right now still evaluating and kind of pulling together what that plan is going to look like for implementation. Of course, that has to happen by July 9, 2025. So we got a little bit of time, but it's going to come up very quickly for us, especially since we're probably going to have some statutory changes as it relates to the MAC. So definitely plan on including the MAC and the TACs for not just this particular implementation, but for a lot of the different final rules that we're going to have to implement.
Okay, that sounds good. And I know that, like I said, the commissioner had given a nice presentation to the MAC a couple of meetings ago, but it might be worth us including that on the next agenda just so that our TAC members are more familiar with what those requirements are and how that BAC might operate. So
yeah, I'd be happy to do that. I think we're just I think we're just a little hesitant to talk too much about it because we don't have our plan yet on how we're going to implement, but possibly by October, we'll have at least some semblance of a plan of implementation.
Okay, that sounds good. And then the last item here is the dental services data request. We got that data report yesterday, and I took a really quick look at it and responded to Kelly with some questions. So I'm not sure that there's much for us to discuss now, except to just get a more a report that's a little easier for us to read and understand. Was anybody from DMS prepared to go over that report with us? Okay.
I don't think so. Emily.
Okay, we'll wait for the next report, and then if we have questions, we can address that either over email or at the next meeting. And I think that brings us to general discussion. Does anyone have any other items that you want to bring to the meeting today? Recommendations? All right. I generally have recommendations, but I feel like we have a lot of information to process right now. And I think maybe at our next meeting, we can be prepared to make a few other recommendations. But for now, unless I hear otherwise, I think we can just go ahead and adjourn our meeting. Well, I'll address these other two items quickly. I'll be representing the TAC at our next MAC meeting. And our last two meetings of the year for the consumer TAC. It's hard to believe we're closing in on the final quarter of the year, October 15th and December 17th. So be thinking about those meetings and the agendas and any items that you want to add there. But we'll plan for now to have a presentation about the Beneficiary Advisory Committee or Council at the October 15th meeting. And I think that'll be really good timing in terms of like preparing for the legislative session and any statutory changes that would need to be made. So I appreciate everybody's time today. Thank you all, and have a good afternoon.
Thank you.
Bye.
Thank you.